Hello, everybody. Welcome. Welcome to today's panel on innovation solutions to reduce barriers to fistula care, linking community health systems, digital health solutions, and specialized surgical care. Thanks for joining us virtually. We welcome this opportunity to connect about this work at a time when we're physically separated from each other. I know we've all had a lot of firsts during this COVID-19 pandemic. Today, for me, a first is moderating a panel with bare feet. But even if we're dressed casually and sitting casually, I know we all take this topic of fistula care very seriously. Before we get started with the panelists, I want to note that any questions you'd like answered today should be submitted using the Q&A box, which is located at the bottom of your screen under the presentation. If you have general systems or technology related questions, please use the chat feature. But if you use the Q&A box, we'll get the questions to the panelists. And we will be doing some Q&A after each speaker today. Well, my name is Tracy Baird, and I'm the president and CEO of EngenderHealth, and I'll be moderating the panel today. EngenderHealth has worked for more than 75 years on reproductive and maternal health programs. We're focused on advancing gender equality, both in and through our programming. And our work on fistula care is critical to our mission because fistula is a significant burden on the most vulnerable of women. Today, we're sharing experiences from EngenderHealth's USAID-funded Fistula Care Plus project, known as FC Plus. FC Plus is an important project in the comprehensive approach it takes to addressing fistula, both repair and prevention, and ensuring that all women with fistula have the respectful care and support that they need. Despite the expansion of fistula treatment in many countries, many women still lack information about or access to fistula diagnosis and care. FC Plus recently completed a research to action partnership with the Population Council and Viamo to address hurdles to fistula diagnosis and repair in Nigeria and Uganda. And today our panelists will share lessons from this experience. I'm going to go ahead and introduce our three speakers and our Discuss It Now, and then I'll turn it over to them to give us the great content that they've prepared. We'll hear first from Vandana Tripathi, who is the director of the FC Plus project. Vandana has conducted a range of research studies on maternal and newborn health. She has led health and human rights projects, and she's also very experienced in reproductive health and HIV/AIDS programs. Pooja Shripad is an associate in the reproductive health program at the Population Council. Pooja applies health systems, gender, and social norms lenses to guide implementation research on health systems in development and humanitarian settings, on provider behavior change in maternal and newborn health, and of course on fistula. We'll also hear from Emma Saxon, who's the Deputy Director of Partnerships at Viamo, where she supports the company's USAID health proposal portfolio. Emma's worked with comprehensive community-based rehabilitation program in Tanzania, as well as with a program researching the impact of educational technology use in low resource settings. And our discussant, Mary Ellen Stanton, is Senior Maternal Health Advisor to USAID, where she guides the Global Health Bureau's maternal health portfolio, including research and implementation of country programs to end preventable maternal mortality. Among other critical roles at USAID, Mary Ellen co-manages USAID's obstetric fistula program. She's helped to develop USAID's advocacy and implementation research activities to address the problem of disrespect and abuse of women during childbirth in healthcare facilities. And we're so pleased she's able to join us today to help with our discussion and tie some things together. So as I turn the mic over to our speakers, please remember to use the Q&A box for questions you'd like them to address. First, we'll hear from Vandana, who'll give us an overview of the formative research and details on the intervention design and implementation. Vandana.
Thanks so much, Tracy, and thanks to everybody for joining us virtually today. It's great to be able to share this work with you. And before I do, I just want to give a little bit of background on fistula. Next slide, please. I know many of you know this, but a fistula is an abnormal opening in the female genital tract that causes uncontrollable urinary or fecal incontinence. The latest estimates suggest that up to 1 million women live with fistula, and there are still thousands of cases every year. We often talk of fistula as obstetric fistula. So that's when it's caused by prolonged obstructed labor that hasn't received appropriate care or timely care. But we also more and more see iatrogenic fistula, where it's actually occurring because of errors, mistakes during surgeries, most often cesarean section and often hysterectomy as well. It can also be caused by trauma, including sexual violence, and the other causes that you see here. Next, please. Through USAID support, EngenderHealth has been working on fistula for a number of years and has been able to support more than 43,000 surgical fistula repairs, train hundreds of fistula surgeons, and also train tens of thousands of health workers in providing related services. Next. The current FC Plus project is working in the countries you see here, primarily in sub-Saharan Africa, and we've also had a substantial program in Bangladesh. Next. Through this project, we've been able to support more than 14,000 surgical repairs, and you can see in the graphic below that the vast majority of these were successfully closed. Next. But from the beginning of the project, we've been grappling with a challenge. We believe that there are women with fistula who have not yet reached fistula services and are not well served by our existing ways of conducting outreach, case finding, and providing services. And we believe this because when we compare estimates of fistula using population surveys or using modeling with the number of women who are served at treatment sites, we still see a gap. So the questions we wanted to answer through this Research to Action partnership were, who are these women? Where are they? What are the barriers that keep them from seeking, reaching, and receiving fistula care? What might help address those barriers? Are there enablers or supports? And at the beginning of this, there are a lot of assumptions, a lot of beliefs, certainly a lot of rich information from fistula programs, but very little evidence. So in this partnership with the Population Council, we started with a literature review and formative research that the council conducted to better understand barriers and enablers. And then EngenderHealth, bringing in our partner Viamo, designed an information screening and referral intervention to try to address specific barriers in Nigeria and Uganda. This intervention was implemented in 2 sites in Nigeria and 1 in Uganda. And then the Population Council, collaborating with us, conducted implementation research to understand its effectiveness. Next slide, please. Now, I want to just tell you briefly about the findings of the literature review and then the formative research. The Council's literature review found that there are basically 9 key barriers that were affecting women's ability to get to fistula care. And they're listed here, and the barriers can really be organized in the same way we've thought about maternal mortality for so long, in the 3 delays model. Next slide, please. What the literature review found was that although there's been so much research on the barriers, there's very little research into solutions, very low-grade evidence. So the formative research helped us dig deeper into the barriers in Nigeria and Uganda. And one of the findings was quite disheartening. Despite years of community outreach, in-person events, trying to raise awareness about fistula, we still see low awareness about the causes and the fact that treatment is available among women with fistula, their family members, and the general public. We also see that stigma remains so high in some settings that women with fistula can't participate in those community events, and they actually can't even talk to people about their symptoms who may have been able to go and learn about the condition. So the implication was that mass media strategies could help us get to those women who truly cannot participate in in-person approaches. The research also showed that that decision to seek care is not made exclusively or even mostly by women. There are many, many gatekeepers in their lives. Next slide. A couple of illustrative examples. A woman with fistula in Ebonyi in Southeast Nigeria told us, I had not heard about fistula before and later, except the woman I told you about. I hid my experience. I didn't tell anybody. Another woman said, it has secluded me and I always keep to myself. It has derailed me in business. I don't go to my shop. I don't go to market. I heard that people started gossiping that it's because I lost my child that I'm behaving strangely. Next, please. The research also showed us that there are tremendous barriers in the health system as well. That primary healthcare, PHC providers, don't know much about fistula. They don't know much about where treatment is, and therefore they can't make correct referrals. And we can think of this as a passive barrier. We also, though, found that PHC providers may even attempt to treat fistula, may may say it's not treatable without the adequate training or knowledge, and that's more of an active barrier. The good news was that while transportation cost was a barrier to care, we didn't see instances of drivers or others actively keeping women with fistula from using transport. And in fact, drivers were quite sympathetic to clients' situation. Next slide. So just a couple of examples here now from northern Nigeria. It was just the lack of money that hindered me from seeking care for 8 years. We were looking for traditional treatment because of lack of money to come here. Yes, no money to come here. My husband hadn't, his father hadn't, my father had to sell some things for us to come here. Healthcare workers should be trained that once a woman has this kind of problem, she should be referred for expert management instead of trying and causing more harm to the woman. Next, please. So the Population Council took this these findings and created this very helpful graphic for us, and that guided our response. So we can see if women in the community are at the far left and appropriate care is at the far right, we see the stages of seeking, reaching, and receiving care and how these different barriers cause women to drop out along the way. Next, please. So we developed a response to try to wrap enablers around women and prevent this dropout along the care pathway. We developed a response targeting the barriers you see listed here, primarily around awareness, cost, gatekeeping, and stigma. We used 3 pathways for fistula messaging and screening, recognizing that different barriers affect different women. The first pathway was mass media with an interactive voice response, or IVR hotline. The second pathway was community outreach agents, and the third was PHC providers. And the consistency was across all of these pathways, the same fistula screening algorithm was used, a very simple screening tool, and the same enabler was provided, a transportation voucher for suspected cases to go straight to an accredited fistula center. Next slide. And this is a lot of information on this graphic. It's the framework for the intervention. The main point I wanted to illustrate here, the goal was that across all 3 of these pathways, the woman is constantly moving towards that accredited fistula center if she is positively screened. Next slide, please. And here, again, not to read everything, but to illustrate, this was only possible, the notion of this wraparound intervention to respond to barriers, this was only possible. And yes, we will be sharing the PowerPoints during the archive. And so the content that I'm not reading, just responding to a question in the chat, the content that I'm not reading, you'll have access to afterwards. So the point here is that all of these partnerships were required for this wraparound response. So of course the fistula treatment centers themselves, but also primary healthcare facilities, community-based organizations, as well as village health teams in Uganda, transportation providers and networks and unions of drivers, and everyone had to have a very clear sense of their role in this intervention. Next slide, please. I want to briefly highlight one of the innovations in the intervention, and that's the IVR screening hotline. You'll hear more about that from our partners at Viamo later on. So we partnered with Viamo to develop a free hotline to screen women for fistula. And the IVR, the interactive voice response, means that when women called the hotline, they received a set of recorded messages in the language they preferred. And if women were positively screened, we asked additional questions about their demographics, the cause of the fistula, and the barriers they experienced. Women who screened positively received follow-up information. And we used IVR very specifically because it's not limited by low literacy. And Emma will talk more about this and the barriers that IVR can respond to later. Next slide, please. We advertised that IVR hotline extensively through community outreach, mass media announcements, flyers, and what you'll see is that it was adapted to the local context, so to specific dialects and imagery that was more appropriate for the setting. Next, please. Because those other 2 pathways, PHC providers and community agents, were also essential in screening and referral, we trained these partners in fistula causes, treatment, screening, referral, and created job aids for them. Very simple job aids for the community agents, a flow chart that you see on the left, and then a more classic intake and screening form for providers. Next, please. The transportation voucher was the final part of the intervention. And this enabled those positively screened women to travel for free to the accredited fistula treatment facility. And because it's not always safe or appropriate culturally for women to travel alone. The voucher also enabled travel for a companion. Next, please. You're going to hear a lot about the findings from the intervention today, but we've also been able to, with the Population Council and Viamo, document the work in a series of technical briefs, research briefs, and journal articles. And you can find them on the Fistula Care website and the Population Council website, and also see more information about Viamo there. So I'll be happy to take any questions about the formative research and the intervention, and then you'll hear about some of the findings from the effectiveness research later. Thank you.
Great, Vandana, thank you. And we did get a couple questions, and please feel free, others, to type more. Vandana, the first question was whether there was a role for fistula survivors, women who have their own success stories in this model, and were they engaged in any way?
That's a great question. And they were engaged in a couple of ways. One, we really, the Population Council interviewed women with fistula in the formative research, as well as in the research you'll hear about from Pooja. And so the intervention was really guided. If you think about it, the only women we can talk to are those who are success stories, those women who actually received treatment, who got to the center. So hearing their stories, for instance, hearing the women who described to us how their own mothers and fathers were crucial in their ability to get to care. Those women's success in reaching treatment really shaped the intervention. So we could take the lessons learned from their successes and bring it to women facing greater barriers. We also, a lot of the time, community agents, people who are doing outreach and screening around fistula are themselves survivors. And so that's less related to this intervention, it's more a program approach. The best advocate for getting to fistula care is a woman who's been through that experience and can talk about it. So that's the way that women who had experienced fistula were involved. Go ahead, Tracy, I see the next question.
Yes, I think what I actually want to jump down to and then come back up, but there's a question about task shifting, and you talked about, Vandana, you talked about certified and successful and trained repair centers. And can you talk a little bit about what the fistula repair service levels are and what the role is to help make that more accessible at the community level? And then perhaps you can roll in an answer also about geographic barriers and how the services actually can be supported in areas where the women can reach them.
Sure. So about task shifting and task sharing, one of the things we really did want to do was to make sure that women who might have fistula were getting to appropriate diagnosis services. So what we wanted was for PHC workers to focus on screening. So education, screening, and referral, and really do a consistent and good job of that. And then to have the clinically involved, the dye tests, things like that. That diagnosis and then treatment happen at fistula centers. And so we applied that model because we saw so many barriers to appropriate care if that was not clear, if those roles were not clear. So that was the emphasis. And the role for community health workers, for PHC providers, is really that screening and that referral. And then of course, when women come back to their communities, follow-on support. Kenny, it's so lovely to see you virtually and to see your question. I hope you are well. I think in your setting, of course, those geographic barriers are tremendous. In the north in Nigeria where we're working, women were also facing barriers related to distance. I think the intervention can be adapted to settings with significant geographic barriers like your experience, but it's very important in a setting like DRC where the distances might be so much greater. It's probably more likely that the screening and referral would help gather a list of patients, a list of potential fistula clients who could then be properly diagnosed and treated through efforts like the mobile outreach teams that you work with in DRC. So I think there are common elements of the intervention that would work in any setting, but it would be adapted to reflect how long women might have to wait, where they might be getting their surgery, and how close that is to where they live.
Great, and Vandana, this is still along this theme. What's the caseload like in terms of community health workers identifying transportation systems, accommodating, and repair services actually being able to serve?
So if it's okay for this question, I'd love to wait until Pooja's presentation, and we'll come right back to this question of how many women were actually found and served through this intervention, and what the caseloads are at the facilities that we were working with.
Perfect. So that question's in the chat box and we will save it, or in the Q&A box, excuse me. And then one more question for you, Vandana. You've described a pretty complex intervention. You showed us the graphic and you acknowledged there were many stages and participants in this model. Thinking about the sustainability of fistula care, which elements of the package do you think could best be scaled up or integrated into broader community health systems or other programs to ensure ongoing support for women who need care for fistula?
Thanks, Tracy. And that's definitely a question that was on our mind as the POP Council began this research. It is a complex intervention. It has a lot of moving parts. We found even in the 1 year of implementation or less that we needed to do refreshers to make sure people understood their roles very clearly. I think I'll talk a bit more about the digital health side of it, and Emma will as well. I want to highlight the power of integrating fistula screening into other community health platforms. That's a piece that I think could be quite sustainable. The tool that we developed for screening is 4 questions, very simple. And we have found in Bangladesh as well that simple screening tools can become part of the arsenal of things that community health volunteers do, community health workers do. And if it's part of a package of services or a package of messages that are always being delivered house to house or in villages, I think it almost makes it normal to consider fistula as one of the things that a woman might be living with after a difficult delivery or after a surgery. So we really think there's a lot of potential for integrating community screening into community health systems. There's also a ton of potential for that digital health piece, the IVR hotline, and I'll come back to that later on. Tracy, you're on mute, sorry.
Thank you, Vandana, I appreciate that. We have gotten a couple more questions in the Q&A box, but I think what let's do is let's get some additional content about the study and the results out there, and we'll hold these questions. I think some of them may also be addressed by the next speakers. So Vandana, thank you so much for sharing the study design and objectives with us. And we're going to turn now to Pooja to share some of the specific findings from the evaluation of this intervention. Pooja?
Hi, thank you, Tracy and Vandana. Good morning, everyone. I'm delighted to be able to present some of the results results and learning that we've kind of come on to learned about together through this collaboration. So I'll just go ahead and get started since there's quite a bit of content. I'm going to try to whiz through some of the introductory slides. So as you can see here, I just want to reiterate on Vandana's detailed background that she just provided, that this study really is the final phase of the research to action collaboration, and it uses the findings that we learned about through the lit review and formative phases to collectively assess this intervention. So just to say, there's a whole plethora of barriers that women face at these different stages in the community, as well as when they reach the primary healthcare facility and finally in reaching the fistula centers, but we focused on the select barriers highlighted. So next slide, please. In terms of the evaluation study goal, so the goal was really to see whether this complex intervention that has been described reduces barriers, awareness, financial and transportation barriers to women's access to fistula treatment, but also to promote better diagnosis and access to repair. So specifically, if you can just click next, thank you. We look to see whether specifically to understand how the implementation of this intervention increased diagnosis as well as care seeking and repair, what role digital interventions and transport vouchers can play. And we wanted to see this from across a range of perspectives. We also wanted to see how the trainings that were conducted through FC Plus and the job aids, the screening tool, for example, really helped primary healthcare providers as well as community agents to diagnose or to screen and refer. Finally, we want to kind of understand a little bit more. I think there was a question earlier around the engagement of community-based referral systems, and to really understand how all these actors came together to promote an effective referral system. So next slide. We conducted this work in 3 distinct geographic areas that varied in terms of terrain, population size, and sociocultural context. So in northern Nigeria, we were in Katsina, in southern Nigeria, Ebonyi, and in Uganda in the central region. And one thing I'd like to highlight here is that the sort of modality or health systems context for providing fistula care did vary across the sites. So in Nigeria, more routine surgeries were available to women at accredited fistula centers, while in Uganda, this was tended to be more of a camp-based or pooled model. So in places where there aren't as many routine repairs happening, we wanted to make sure we captured some of the findings in those areas as well. And just to say, there were intervention and comparison areas within each of these settings. So we can go on to the next slide. We applied a pre-post mixed methods design, so essentially collecting data across 3 phases: at baseline or before the intervention, at midline, and at endline. As you can see here, there was quite a bit of data collected, both qualitative and quantitative. We conducted 238 facility assessments of primary healthcare facilities just to understand the context of the context in which primary healthcare providers were working in. 591 provider interviews, 410 post-repair client surveys with women, as well as in-depth interviews, which I think really taught us about the hows and what some of the nuance in how the interventions were working and the implementation challenges as well. So these interviews, as you can see in the box below the table, really focused on getting perspectives of post-repair clients, as well as those involved with the implementation of the intervention. Finally, we conducted, we conducted 34 focus group discussions to understand how the intervention affected some of the community attitudes. We heard a little bit about stigma and awareness previously. So how did these things change? And finally, we drew on some of the programmatic data provided through FC+. So that included some of the call logs, Viamo call logs, as well as other registers. So we can move on to the next slide. And you can keep going. Thank you. So in terms of, not only were we interested in reducing barriers, we really wanted to understand whether we were able to promote access and diagnosis. So I'd like to draw your attention, I know this is a bit busy, but to the darker blue and the darker green lines, which speak to the fistula diagnosis and numbers of callers into the hotline, so the mobile IVR. And as you can see across the 3 sites, the figure demonstrates an overall increase in the volume of fistula cases diagnosed and number of callers, particularly in the earlier phases of implementation. While you can see there is a bit of variation in the intervention activity across the 3 sites, it's important to note Ebonyi had sort of the highest level of activity, and this was likely given it had the longest intervention exposure. Next slide, please. This data draws from the programmatic outputs that I mentioned earlier. And as you can see here, there was quite a high volume of calls across the sites here. And between 70 and 75% actually screened positive using the screening algorithm developed by FC+. So getting back to that question or point about simple tools can actually be quite effective. And among those, out of those positively screened, 46 to 54% were referred through the intervention and actually diagnosed with fistula. And also as an interesting spillover effect, we wanted to highlight that there were quite a few callers from outside of the intervention areas in both Nigeria and Uganda, which I think is promising and an interesting learning in terms of reach when it comes to the hotline or digital strategies. Next slide, please. So when we're looking at some of the qualitative data, that we found that mobile screening can certainly influence women's awareness and access when integrated with complementary community and health systems referral mechanisms. So what this means is that it's aligned with the community health messaging and health promotion activities, that there's sufficient publicity around the hotline and support to kind of sustaining that hotline from different types of mass media strategies, radio, television, et cetera. We also note the importance of phone ownership and connectivity. So as you can see from some of these quotes, while the respondents did describe limited mobile phone ownership, poor cellular network connectivity, and some language concerns around the IVR as challenges to the hotline's effectiveness, there was also quite a bit of concurrence around its ability to reach women who are stigmatized. So this issue of women who are really silenced and maybe particularly vulnerable, if they have the access, they can actually, access to a phone or something like that, they actually may be able to better sort of voice their needs and get screened. So we can move on to the next slide. In terms of the transport voucher, actually we found that the vouchers uptake was generally low across the sites. Though there were certainly benefits, as you can see from the quote, and some challenges around the implementation of the voucher. Why were these numbers so low? In some cases, the geographic, actually the fistula centers were close by to some of the women, or there were alternative modes of transportation available to them. So that was one sort of explanation. Another explanation was really around the level of effort that it took to coordinate the transport vouchers on the part of staff, EngenderHealth staff, Fistula Center staff, and the different groups that were involved in actually administering this. So that was one big concern. And finally, just that through the Fistula Care Plus project, there were alternative transport reimbursement mechanisms that were in place in some of the settings. And so it was a bit tricky to see kind of sort of why the transport voucher, didn't maybe work as well as some of the other parts of the intervention. So next slide. So this slide really focuses on the effect of the intervention on primary healthcare provider awareness and ability to diagnose and refer for fistula. The text in red indicates increased proportions in the intervention areas, while the orange indicates that in comparison areas. So if you just click once, I think, yeah, thank you. In Uganda, there was an overall better spontaneous recognition of leaking urine as a danger sign. And this increase was greater from baseline to end line in the intervention district than in the comparison area. There were also slightly greater increases in recognition of patients with prolonged labor in Nigeria, and across the sites, as you can see here, there were significantly greater increases in the recognition of patients with leaking urine and feces in intervention areas at end line compared to the baseline. And finally, there were some moderate increases in terms of the numbers of referrals of women that screened positive, so suspected fistula cases, by primary healthcare providers across the sites. Qualitatively, though I'm not presenting that data, I just wanted to say that we have seen that providers describe the utility of the job aids in kind of as reminders to counsel women that were experiencing incontinence. So even if they didn't fill every single job aid form, they found it useful as a sort of a memory jogger. So we'll move on to the next slide. We learned that the complementarity of community agents, whether it's with the hotline or with primary healthcare providers, was critical to effectively screen and refer women. So for example, a few community members had heard of the hotline or radio through mass media communication strategies, for example, a billboard, but had challenges in recalling the actual number. So this is where a community health worker or community agent could be quite helpful and reinforcing of that information. Also, it's important to strengthen working relationships between primary healthcare providers and community agents, as you can see from this quote, the second quote from the health manager here. And finally, I think one big sort of learning was that awareness building was critical when it comes to not only understanding the danger signs and symptoms of fistula, but also the options, the consequences, and then the options of care available. And the importance of that being reinforced through multiple channels of information. Moving on to the next slide. So this slide speaks to some of the qualitative data we collected, the focus group discussions. So kind of understanding community attitudes. And we found that there was quite a bit of increased knowledge in terms of the causes and consequences of fistula, as well as the care options. So we saw reductions in myths and misconceptions at the level of the community in intervention areas. We also found that more and more people in the intervention areas across all three sites, but also in some of the comparison areas, identified causes or precursors, potential precursors to fistula, like early marriage and prolonged labor, as well as iatrogenic and sexual causes of fistula. There were some lingering misconceptions that varied a bit across the sites. For example, family planning, a side effect of family planning was one misconception in Katsina, and the notion that fistula could cure itself was one belief in Uganda. And one thing that's really interesting, as you can see from the quotes, was that there was an increased sort of sympathy and empathy for women with fistula, living with fistula in these areas, which I think speaks to some of the awareness building strategies that were a part of the intervention. And finally, just to recognize that the intervention exposure varied, and that was seen even at the community level. For example, community members report knowing some of the community agents in their area, and that being an important part of actually sort of receiving the information from them and trusting the information from that they were given from them. But few reported knowing the specifics of the hotline, so the number and what exactly they needed to do around that. In comparison areas, there was just in general fewer, the groups tended to speak less about the hotline, and also didn't necessarily know their community agent in the area. Though I would say this is slightly different in Nigeria and Uganda, given the BHTs in Uganda are part of the health system, and so that group there was slightly more recognition and knowledge of those community agents. Next slide. So yeah, you can just click 2 more times and then I can just speak to, thank you. So we carried out in country disseminations at each of the 3 sites to validate our learnings and elicit stakeholder reflections. And this included subnational, national decision makers, implementing partners, and those involved with the evaluation and/or implementation of the intervention. So during this process, we really found that there was a real consensus around the importance of awareness building, and sort of that being a key output or a sort of learning from implementing this intervention. So we see some examples here from Ebonyi and Katsina in Nigeria, where the state primary healthcare development agency agreed to use some of the Fistula Care Plus training materials, including some of the screeners, as a part of their orientation and trainings associated with the restructure of primary healthcare centers, as well as training some health providers at secondary facilities as well in the new policy context there. We also see some local solutions that were raised or committed to as intentions. There in Ebonyi, a desk officer at the LGA level to link women to care, and in Katsina, building on the corporate social responsibility of media houses, there was an interest in publicizing options for fistula care. And in Uganda, the sort of importance, the group there, the technical working group at the national level, really kind of said it was important to integrate the study findings into some of the ongoing policies that were under review and discussion at the time. In terms of the hotline, I think across the sites, this was seen sort of as a challenge in terms of sustainability, but as an important reinforcing mechanism to build awareness at the level of the community and as a one tool to shift care-seeking norms. And finally, in terms of the transportation vouchers, though those didn't function necessarily as well as we thought, there was a sort of shared agreement that it was important to promote free transport. And there were a number of solutions proposed, as you can see in the parentheses. I'd like to stop here. I know I'm running out of time. And I'd like to turn this over to Vandana for some reflections at the programmatic level and the project around the project implementation overall.
Thanks, Pooja. Next slide, please. So as you can see, the council brought us a tremendous amount of information, really rich findings. And we wanted to piece these together and really answer this question of, so what worked here? What didn't work? What would we invest in again as a program? What would we want health systems to try to take on? So the first overall piece is we found that we see from this work that implementing an intervention to address barriers to fistula care is feasible and effective if you have strong local partnerships and resources. So we took the numbers that you saw earlier, the number of callers, the number of positively screened women, and we applied models from prior research. So what % of positively screened women turn out to have fistula? And then we looked at population estimates. And we estimate that the intervention identified about 200 fistula cases, new fistula cases that weren't in the health system before. And if we look at the number of cases that are estimated to be there in the population, in Ebonyi, this is actually 15% of the estimated cases. So with a relatively short intervention, that's a positive finding. And I highlight Ebonyi because if we think about our theory of change, that was a part of Nigeria where the formative research found the highest levels of stigma. So if we think that the hotline, for instance, can cut through stigma, we want to see a lot of cases identified there. So this was a really interesting finding. In terms of what worked, even though we have, sustainability is a thorny issue to think through, the digital health piece, that IVR hotline, did really increase women's ability to seek fistula care. Hundreds of women called that hotline. 3/4 were positively screened. And we also see that the calls peaked in the first quarter, that the hotline was live. So for us, that has interesting implications for how you might scale this up, whether you might do staggered or pulse campaigns in different areas to try to capture that initial burst of response. A surprising finding for us was that we thought community agents would use that simple job aid and women themselves would use the hotline. But in some settings, community agents themselves had very low literacy. So they found the hotline really helpful in facilitating screening. So being there with a woman, helping, but actually going through that screening algorithm on the hotline. As Pooja showed you, we did see positive effects in terms of knowledge among PHC workers and in community agents. It seems like there's evidence of better, more positive attitudes in the community towards women with fistula. So those were things that were positive findings and that have potential for integration into other digital health and community platforms. I think as you see, we found that the transportation vouchers, for some women, they were really helpful, but the uptake was quite low. And those are expensive and complicated to set up, so that might not be a thing to try to do again. Unfortunately, you see positive increases in care seeking and screening in referral and diagnosis. We could not, with the data we had, though, infer directly that the intervention led to more repairs. So that's a piece we don't have an answer right now. And I think that speaks to how hard it is also, though, to connect data from the community all the way along that pathway to treatment. So which women getting treatment were actually there because of the intervention versus who would have been there otherwise. And the last thing I want to highlight is how challenging it is to measure barriers. Next slide, please. So we didn't show you this slide before. The council interviewed women at baseline and endline who had received care to ask them about what barriers they had experienced. What were they reporting? Was it awareness? Was it stigma? Was it transport issues? And we realized looking at this that it's actually very hard to interpret this to try to connect the dots to the intervention's effects. You could see if a lot of women at Endline are reporting high levels of barriers, it could be because that intervention helped those women facing the most obstacles get to care. On the other hand, if women at Endline reported lower barriers, maybe it's because the intervention took those obstacles away. So I think we really learned very collaboratively here the challenges of connecting the dots between the different types of data sources and how complex it really is to understand how barriers influence women. But I think for us as a program, we see a lot of pieces of this having tremendous potential for adaptation and integration into other interventions. Thank you.
Great, thank you, Vandana, for those additional thoughts, and Pooja, thanks so much for your presentation. As you may be seeing in the Q&A box, we have a lot of great questions. And just picking up on something Vandana just mentioned about integration, could one of you comment a bit on the potential to integrate more of the screening and referral aspects into other types of care that are going out to the community setting? The person in the Q&A box asked about cervical cancer screening. Also, what about immunization programs, family planning programs, and other things that have health outreach workers?
Pooja, do you want to comment, and I can follow up, or?
Sure. I think the screening tool, and you can definitely add to this one, that is very specific to fistula, but I think what it does highlight is that if you ask a few if you can figure out what the key questions are to ask to be able to, at the community health level, for example, or through a IVR platform or something like that, that you are able to simplify screening to some degree for certain conditions to be able to at least detect cases where there might be suspected cases of fistula or other illnesses or other diseases. So I think the idea here is if this could be built into, for example, a reporting form or some routine data collection, I think there's certainly potential there.
Sure, thanks, Pooja. Yeah, I think there's a tremendous amount of potential here. And I'll use two examples. In Uganda, and there is a follow-up question about village health teams. In Uganda, those village health teams do a lot of work, right? Well, the policy is changing, but their scope of work was quite comprehensive. And so integrating a few fistula questions into their scope of work was a way to expand access to fistula screening without creating a whole new or separate system. And in Bangladesh, what I alluded to before, the community health volunteers that we trained to do fistula screening, they were already going house to house, looking at a variety of maternal health issues, newborn health issues, family planning issues. And so adding a few very simple fistula questions to that work, again, has a lot of potential. I think the important thing is to be sure to recognize that these folks get overloaded. They're asked to do a lot. And if we're going to maintain the quality of the screening, it requires refresher training. It requires, I think, supportive supervision or access to someone that you can text or speak with to make sure you're doing it right. With fistula, the challenge is incontinence can be there for many, many different reasons, right? So we want to make sure we're asking questions that try to help identify causes that can actually be treated, and to not have thousands and thousands of people overwhelming a diagnosis site who don't actually have fistula or a condition that can be treated. But the potential is definitely there. And I had not thought about cervical cancer. I think that's a really interesting point. I was thinking more about integration in maternal health and family planning platforms, but that's an excellent point as well.
Great, thank you so much. And so we keep to time, we're going to go ahead and move to our next speaker, but we are holding these questions. We won't lose them, and we hope to have time for more at the end. But now we have the opportunity to hear from Emma, who will share more about the IVR hotline and reflect on the potential of this specific digital health solution. Emma?
Great, thank you so much, Tracy, and thank you to Vandana and Pooja for their fabulous presentations to really provide a comprehensive understanding of this intervention with FC+. I'm so grateful to share some lessons learned from our experience using an IVR hotline. So let's kick things off. Next slide, please. For some background context, for those of you who might not be familiar with Viamo, we are a global social enterprise, and our core belief really is that information is power. We envision a world where all people have access to the information they need to make decisions for healthy and prosperous lives. And we do that by powering two-way communication at scale between organizations and the people that they hope to serve. We are experts at optimizing content for mobile phones so that we can reach target audiences on devices they already own, on channels they're already familiar with, and in the language that they understand. Next slide, please. Some quick background context for this intervention. We use mobile as a way to communicate information because there's simply no other communications channel that has a larger reach than the mobile phone. Right now, there are more mobile subscriptions than there are people on the planet. And I think an especially relevant statistic is that 1.7 billion women now own a mobile phone. Through the mobile device, we find that we can communicate information quickly, cost effectively, interactively, and in a highly targeted way, all the while being able to measure the results and the impact of that information being shared. Next slide, please. One of the primary technologies that we use at Viamo to communicate information is interactive voice response, or IVR, which has been discussed a bit in this webinar today. IVR is an automated telephony system. It's the same system you use to check your voicemail. And at Viamo, we have found that IVR is a really incredible tool. By leveraging the power of voice rather than text, we can overcome challenges like distance, infrastructure, language, and critically, literacy barriers. This is, of course, very relevant when working with populations that might have low or no functional literacy. IVR can also ensure a more inclusive feedback loop, making sure everyone's voices are heard, and it allows us to be able to share information with pretty much anyone who has access to a mobile phone. Next slide, please. Just a quick overview of how Viamo's implementation process works. I won't go too much into this, but we really think of ourselves as a tech partner and a communications channel. EngenderHealth are the experts, right? So we use a human-centered design approach to work with our partners, who are the experts, to design content that Viamo will then optimize for mobile phones. And we do quite extensive field testing to make sure that the information we're trying to share is culturally relevant, is accurate, is contextualized for that specific community, and of course, iterated a number of times through focus groups and different A/B testing before it is actually shared. Next slide, please. We were really thrilled to have the opportunity to pilot this IVR screening tool with FC Plus and to support the really critical work that Engender and Pop Council are doing to understand and transcend these barriers. Vandana already kind of reviewed some of these major barriers that keep women from seeking fistula care, but just as a reminder, before we kind of discuss how the IVR tool can help, major barriers are the stigma surrounding the condition, gatekeepers, who sometimes include providers who are not well informed about fistula. Women can receive inaccurate information and even unskilled attempts at fistula treatment. Many women with fistula are socially isolated and cast out from their homes and unable to travel to a facility because the facility might be too far, cost of transport might be too expensive, and of course there's the opportunity cost. Most women are caregivers and they can't afford to leave their families home alone. And lastly, literacy remains a huge barrier. Even if fistula messages are transmitted through SMS or other written formats, those channels are probably not effective at reaching a large population of women with fistula who are not functionally literate. Next slide, please. So in order to try and overcome some of those challenges and support FC Plus, Viamo designed an IVR hotline that women could call to be screened for fistula symptoms over the phone. And we used a screening algorithm that was able to direct the women who were screened positively for fistula to an action message that included a referral, which I'll speak about in a few moments. And Vandana and Pooja have already described that this intervention was part of obviously a more comprehensive package that included a mass media campaign. So there were flyers, posters, radio advertisements, trying to make sure as many people as possible knew about the hotline. And how the hotline worked was when a woman called, she would hear a pre-recorded voice that would ask her first to choose her language, so that of course they could communicate with her in the language that she understood. And from there, the woman was asked a few initial intake and screening questions. And depending upon the outcome of those questions, the algorithm would give her an action message. Next slide, please. So here's the script for the first thing a woman heard when she called the hotline, which is the welcome and introduction message. It has a really friendly tone, and very quickly into the message, it describes the symptoms of fistula, making sure that right away you're able to catch a woman's attention if she is in fact experiencing those symptoms. The message also encourages listeners to answer the screening questions they're about to hear honestly, so that a recommendation can be made on the correct course of care. Next slide, please. So these are the initial intake and screening questions that a woman would hear. They would be asked their age, if they were experiencing incontinence associated with fistula, and if they lived in the intervention areas. And if a woman answered yes to the question regarding her symptoms, she would then be asked a series of questions about her demographic background, why she might have had fistula, perceived cause of fistula, and any barriers she might have experienced with trying to seek treatment to date. Next slide, please. And after that's the screening process, if a woman was screened positively for fistula symptoms, she received an action message that included a referral to a regional treatment facility. So this example is from Uganda, where women were referred to Katovu Mission Hospital. I think it's important to note that the first message kind of in this general referral is that fistula is curable, and that the woman who is listening on the other end of the phone would be able to receive treatment for free. The message then goes to describe the process, which is that within 2 days, a community agent or village health team volunteer would follow up with her, would call her on the same number she used to call the hotline, and provide her and a companion with the transport voucher to a facility in order to get a proper diagnosis. And if that woman was in fact diagnosed with fistula, the community agent or health team volunteer would be in touch with her again to arrange additional transport so that she could receive proper treatment. It's also important to note, I believe Vandana noted that there were calls from outside the intervention zone, and a number of women who completed the screening process and were screened positively, but did not live in the intervention zones, received a follow-up message through both SMS and IVR that gave them information about the nearest fistula treatment center to them. Next slide, please. Pooja already did a really wonderful job of summarizing the findings and the output of this action to research experiment. And here are just some of the top line results, kind of as a reminder. Over the 10 to 12 month implementation period, 566 women who called the hotline actually completed the full screening process. And of those 566 women who did the screening, 73% of them, 415 of them, were screened positively for fistula symptoms. And if you haven't already, I really encourage you to read the EngenderHealth article that Vandana and Pooja and their colleagues have published, which is linked here, which provides many more details about this intervention if you are interested. Next slide, please. Some of these implementation challenges have been discussed thus far, but here are the ones that were most pertinent to using this IVR hotline. Gender played a really important role in a lot of these challenges. For instance, while many women have access to a mobile phone, few women actually own their own mobile phone. So for instance, if multiple family members are using a single phone, it can be difficult to ensure confidentiality, to make sure a community agent is following up with the correct woman who called the hotline. Cellular network connectivity posed a serious problem. Some women were just unable to actually reach the hotline because of their connectivity issues. And there was some great feedback on this and some good workarounds. In some places within the intervention zone in Uganda, community agents found that there was better connectivity at night, so they'd encourage women to call then. Or if a village had a certain hotspot where there was great connectivity, that information would be shared between peers, but obviously a huge barrier for women being able to do that screening process. And of course, one concern that many women had was whether or not their calls would be confidential, tying back into really entrenched societal stigma around fistula. Next slide, please. While the implementation had its challenges, and Pooja described some of these pieces of feedback, we did receive positive feedback from both community partners and women who used the hotline. They believed that increased community awareness of fistula, the anonymity aspect of the fistula line was considered to be a major positive of this tool. And a number of women noted that the messages on the hotline helped reduce their internalized stigma kind of around disclosing fistula symptoms. Next slide, please. So I wanted to briefly share a case study from another intervention with a fistula screening hotline, because I think that there are a lot of interesting parallels here, especially around the question of sustainability. So in Tanzania, we've been working with CCBRT as our community partner, and with Vodacom, who is our mobile network operator partner. Viamo has pre-negotiated agreements with mobile network operators in about 18 of the countries where we work. And through those agreements, we are able to host a national free hotline using IVR that we call the 321 service. So in Tanzania, if you're a Vodacom subscriber, you can call a short code like 321 and access a menu of topics that are spoken to you through IVR on everything from health, agriculture, education, to dynamic content like the weather or the news. And we worked with CCBRT to develop a bundle of messages about obstetric fistula, which we then hosted on the 321 service, which is incredibly popular in Tanzania. And within those messages, there was a call to action that referred anyone who thought that they might have fistula symptoms to CCBRT's own fistula hotline. And I'll describe the results of this in a moment, but a couple of the most salient lessons that we learned was that a lot of people don't know what fistula is. It's a word they've never heard before. So we decided to nest it in the category on 321 that is titled complications after birth. This is one of the categories that receives the highest volume of traffic to 321. And so we knew that a lot of women would be listening to this category, and we thought we might be able to reach women who were experiencing fistula symptoms by kind of recategorizing it. The 321 service also has about a 50-50 gender split. So we really want to be sure to include men in the call to action and make sure that they're taking part in the work around fistula awareness, which Pooja mentioned was such a critical output. Next slide, please. And some top line results from this. This was about a 3-month implementation period that's still ongoing today. We got about 300,000 calls to the 321 service that then listened to the fistula messages, which translated into over 1,000 calls to CCBRT's fistula hotline, which is fantastic. Next slide, please. Overall, some major lessons learned from this was that IVR-based screening tools can be really effective in some scenarios. And a number of the things that we thought about were, can we reach people who might have low literacy? Can we reach populations that are geographically dispersed? Can we reach people who maybe are struggling with stigmatized conditions? And we found that to be quite true with an IVR-based tool. Of course, it needs to be publicized extensively so that people know that the hotline exists. So when there's complementary advertisement support, mass media campaigning, it can be really effective. Next slide, please. General recommendations. Many of these will be repeated from Vandana and Pooja's great presentations, but the key here really is integration. IVR-based solutions need to be paired with complementary community and national health systems to be ordered to complete the referral process, support women, and make sure they get the care they need. These tools are purely supplemental. There will never, ever be any replacement for face-to-face interactions with healthcare providers. So we really think of a tool like this hotline as part of the greater puzzle. Publicity, of course, is a huge concern. In order to be effective, hotlines not only need to be promoted widely, but also frequently. So trying to understand what your target audience uses as means of gathering information. Are they listening to radio? Are they watching TV? Are they getting promotions from their telco or mobile network operator? And then from there, how often are they doing those things? How often are they getting that information is a great question. National support, very critical as well. In Tanzania, all of the messages that we host on 321 are approved by the Ministry of Health. It's our protocol to make sure that all government stakeholders sign off. But we actually got the endorsement of the government. The Vice President of Tanzania recorded those messages and included a call to action for all Tanzanians to really take part in the fistula awareness campaign, which we think was a key to the success of that intervention. And then sustainability mechanisms. Of course, you need to make sure that these hotlines can be extended for long periods of time and be able to support the referral of as many people as possible. CCBRT uses community ambassadors who travel around Tanzania and are able to refer women in their localities. We can ask our friends in the private sector and the media to sustain fistula awareness campaigns through different means of communication like radio and TV. And of course, making sure local partners, if they're interested, have the capacity to manage the hotline. In a lot of the projects Viamo does, once the project cycle ends, we train up our local teams to make sure that they're able to manage the hotline moving forward. And finally, next slide, please. Some questions to consider when you're thinking about scale. Mobile phone ownership is a huge concern, network connectivity, how you're integrating whatever type of solution you're using with existing systems. And of course, you'll never be able to replace in-person contacts. And with that, I'll end there. Thanks so much.
Great, thank you so much. It's so interesting to hear the details of this, and thanks for the comparison to the program in Tanzania. Just given time, I want to see if we can fit in a couple of questions. I'm going to combine them for you, and you can.
For sure.
We have great questions, and we'll see if we can get answers organized for those and sent out with the slides and video, because I'm not sure we'll get to all of them today. But one thing Vandana talked about when we started was that there are a lot of gatekeepers and a lot of people preventing women from accessing care. Can you talk a little bit about those who are supporting her, who are going with her to seek services, who are her companions in that process? And also, again, from a woman's perspective, we know from other studies on other topics that women using phone access to information, it's not always her phone or only her phone, and it can potentially put someone at risk. So in terms of the fistula care, content, is that something that was looked at, and how safe and confident were women in using what might be a family phone to access this information?
Yeah, that's a great question. And quite honestly, something that Viamo is kind of perpetually trying to understand in all of the work that we do. And of course, the gender split with our work differs depending on community. But I think this ties back to, I think it was Pooja or maybe Vandana who mentioned that normalizing the conversation around fistula. We found that in Tanzania, including men in the conversation, having mass awareness campaigns, having the Vice President of Tanzania speak to what fistula is really trying to take away the aspect associated with shame or any type of concern that a woman might have fistula or be trying to find out if she has symptoms. We do a number of different types of surveys and studies around, and a lot of times we analyze the data we get on phone usage in specific communities to try to understand how we can reach women and when we can reach women. This is far from a perfect way of trying to make sure a woman is actually answering the phone. And to be quite honest, I don't think there are any easy answers with this, but it's very context based. And we've done a number of, I'm trying to think of what country it was in. We did a study recently in a country where we found that women who were caretaking in the home were the ones using the phone from a certain period of time. So making sure that push messages, which we can do, or mobile surveys or robocalls were called then and had an introduction message that said that they were asking for women in the house. I'm not sure about, I can't really speak to the support that women had. So maybe Vandana or Pooja, you can share more about who were these companions who were traveling with women to facilities, if you have those details.
It's very, thank you, Emma. Very quickly on the piece about violence and the shared phone. That was one of the adaptations. We looked at the intervention as it was going on and made changes to reflect with these realities. And this issue of confidentiality and risk was really important. So messages were developed. So for instance, when the community agent called back to facilitate that referral, for her to have an introductory script that was very general and didn't say, you called us about fistula, just say, oh, did you recently call, a hotline or to get some information, finding innocuous ways to begin that conversation and not speaking about it to anybody else but the woman who had actually called. With accompanying persons, we know that parents, mothers and fathers were really, really important in supporting women in getting to care. But Pooja, do you have more specifics on that from the Endline interviews?
I'd have to go back and check, but I think also other mothers and fathers or siblings were also mentioned. Beyond partners also were mentioned, but I'd have to go back to kind of see what the breakdown is. But it is sort of whoever it is, it's variable woman to woman. So I think it really, some women describe their partners as their main support actually, and some describe their other family members. So I think it really does fluctuate.
Great, thanks to each of you. And again, we'll try to get to more of these questions. But now I'm really enthusiastic to turn the mic over to Mary Ellen, who will reflect on the learning from this experience and especially the implications for future programs. Mary Ellen, thank you.
Hello, everyone. Thank you so much for those presentations. I thought that I couldn't speak today without mentioning the passing of Dr. Catherine Hamlin. She was such a visionary in highlighting and then providing excellent care for women suffering from fistula. I know that I personally learned so much from her, and I think the work that people and organizations are carrying out today to address this problem of obstetric fistula, whether directly or indirectly, have been affected by her work. And so I did want to mention that. I think our world globally is changing in that there has been increased awareness about obstetric fistula and certainly increased in services. And in recognizing what has happened, we are also so aware of how much more needs to be done. In this area, we keep talking about backlog of cases. But I think today that what we're really working on are the hidden cases. Women living with a problem that has affected their lives, and yet they may not have been touched in any way by health services. This whole set of presentations to me really has implications not just for the problem of fistula, but also it opens up possibilities for seeking out and addressing problems of that relate to other chronic conditions and other stigmatized conditions, to the whole area of care seeking. I do think that it was very interesting that they started from a 3-delay model, which is so often used because it just helps us categorize our problems in terms of buckets of issues. And yet I like to come back to thinking about that in terms about the interaction and overlap with the 3 delays and how seeking care may be so dependent on people's perception of actual care, biomedical and interpersonal care, and that the set of interventions, the complex interventions that were described today fit in a broader healthcare system, and whether we can actually deliver life-changing, effective surgery in a respectful manner in areas where we're putting out these messages and reaching out to women to seek them. There's not much time. I did want to highlight something which I think is a real breakthrough and that was talked about a lot, the simple screening tool. When we look back on the history of this, sometimes we heard stories of women saving money for years to get on a bus, to travel for 7 or 8 hours to a hospital where they would go and be screened for the problem. And sometimes for some of them, they couldn't, the problem couldn't be fixed there, or they didn't meet criteria or whatever, and they had to go back and make a return to a village without the problem being addressed. In other cases, women were invited in and had to stay sometimes months in order to get a place on the operating room schedule. So the whole idea that a reasonable screening can be done for women where they are without making these major decisions that can be financially difficult and time-breaking really is quite a breakthrough, and put within the interactive voice system and the outreach to community health workers. It is a wonderful drawing together of these various new learnings and tools that we're putting in place. I did want to say about the presentations in terms of implementation research that many questions come forward, and great questions that have come here. What I would like to do is to call out the honesty of the researchers in reporting difficulties in finding answers to questions they wanted to find the answers to. Did more women get repairs as a result of this complex intervention? Vonda said the jury's out. We don't really know yet. This is sobering. And yet it is, I think, a real reflection of the research integrity to be able to share that conclusion and seek further information on how we can get to women who are themselves hidden and their conditions are hidden. Another example was even how to interpret the barriers. If you're doing a good job with awareness raising, then these barriers loom up more, and then you don't find the results that you broke down barriers in the same way. So it's complex, and I just appreciate the researchers bringing forth these conundrums in looking at what are the conclusions and the learnings, the important learnings from this research. So in summary, I want to thank EngenderHealth and Population Council, Tracy, Vandana, Pooja, Emma, for the work in sharing this, and for all of the many participants who are on the call for their excellent questions. I leave it to Tracy whether there's time to take any more questions.
Great, Mary Ellen, thank you so much. Absolutely appreciate your acknowledgement of Dr. Hamlin and the massive contributions she's made and inspiration she's provided on the topic of fistula, and just how many women, both women who experience fistula, but also the women who are involved in this sector and this work that she supported and inspired during her life and career. Also really appreciate your comment about the need to be honest in this research. When we do research that is designed both to help us learn, but also to help the women who are there in front of us now, research designs, as scientific and careful as they can be, often do leave us with results that, as you noted, can be hard to interpret, and we have to embrace those data and those results in their complexity and continue to make sure that we're serving women now, while we keep a careful design and hope that through that learning we can serve even more in the future. So thank you for those comments. And of course, thank you so much for USAID's partnership and support on FC+. I do think that we have time for another question or two. I want to bring up a theme that's come up in several questions, and that theme is around money and resources. So whichever of the panelists would like to jump in, there's been questions about whether volunteers and volunteer health teams and communities are compensated for their work, what the cost is for women in terms of staying for care, even if transportation vouchers are provided, and the dynamics of providers and whether we have risk of providers who aren't fully trained and equipped trying to provide repair or other related fistula care because they could be compensated for it. So just maybe some general comments around how the economies of fistula care are working and what that may do in terms of facilitating or hindering access for women.
Who would like to take a crack at that? I have some thoughts, but I don't want to monopolize the time.
Why don't you go ahead and I'll add.
Thanks. Well, the first thing I want to say is actually a referral to a publication that the Pop Council team put together. It's called Poverty is the Big Thing. And it's an incredible analysis of the cost issue, where those costs come in, where women experience the most barriers related to finances. And so if you literally Google fistula care barriers or Population Council and fistula, you'll get to a page that has that. In our first presentation, we have that link. I recommend reading that. I also want to quickly say we have so many amazing questions. I think our team will commit to creating a blog, short responses to all of these that will get up on our website in the next few days. We want to get the slides to you immediately, but we want to answer these questions thoughtfully. So we will put responses up. It's absolutely true that for some people, it's not getting to the facility and it's not the surgical care. Those can be made free. It is the cost of living near the facility. It's food. And some fistula centers are able to offer the support for those costs to make them free for the woman, and others are not. So those are definitely parts of the barriers as well. And I think we've learned a lot from this work about which barriers are the kind of, if you think of the 3 delays again, which barriers knock you out earlier in the care pathway versus which barriers come later. And so if you think of, let's eliminate the ones that come earlier so that women actually have a chance to get to care. And that's where programs like ours can help support the costs that come in later. I think we don't have enough information to say that perhaps providers were trying to treat or manage fistula purely for financial reasons. I think lack of awareness is a big part of it, not knowing that there's somewhere else to refer her. But it's a question. It is a question whether there are improper incentives to try to treat at a lower level. Regarding community health workers, village health teams, et cetera, when we were working, we were very lucky because the VHTs were part of the Ministry of Health. They were affiliated with the healthcare system, and they were functioning well. But of course, sustaining that is very challenging. And I know, Pooja, if you want to speak about the changes in the VHT policy and the implications there for sustainability.
Sure. Well, actually, the policy is still actually in question, so it hasn't been quite decided. But just the brief answer around whether or not community agents or community volunteers were paid in the context of this intervention. So I think with VHTs, they're supposed to be provided a stipend, but they're actually not. In the former version, we're not paid like salaried workers, and so they could be compensated on top for helping with certain programs. So in our context, they were supported in the context of this program. And same with I believe the community agents in Nigeria. Those are part of local community-based organizations, women's organizations. But in the context of this work, I do believe they received a bit of financial support. So just to say that there is, I think, an importance to understand incentives at the community health worker level, absolutely. And I think it does affect at least even sort of initial, just their ability to do the work that they do, even though a lot of community health workers are motivated for many other reasons. So, yeah.
Thank you. I mean, again, going back to one of the earliest comments in Vandana's opening presentation, there are a lot of gatekeepers between women in care, and with the health teams and with the hotline and with providers and with parents and siblings and partners who care for the women. I think an important role for us as a community is to ensure that there are many, many facilitators to help women find that care. And as Mary Ellen mentioned, you know, any keys we have to unlock options for screening and to help facilitate that process so that women can get to that care as expediently as possible. So thank you all for that. And Vandana, thank you for mentioning that we'll get these questions answered. This work has been a real example of how powerful it can be when health service interventions are designed to reflect the experiences of women and girls, particularly the highly gendered barriers to information and care that many, many women and girls continue to face. This work also reflects the power of partnerships, both among the organizations presenting and discussing here today, and also among the many partners at the country level that are actively engaged in designing, implementing, and learning from FC+, and work on fistula care more broadly. I can see the names in the Q&A box, and I recognize many of you, and thank you and honor you for the enormous contributions many of you make on this topic, past, present, and future. So we look forward to continuing to engage on fistula care and also on other aspects of reproductive and maternal health. I really want to thank all the panelists today, and you all did a great job, Emma, Pooja, Vandana, and Mary Ellen as our discussant. I also want to thank USAID for making this critical work in fistula care possible. And I want to thank the EngenderHealth team in the background, Zandria, Gayatri, Lataska. We have people forwarding slides and people managing chats and getting our tech set up. So thanks to all of you. Hope that people will visit the EngenderHealth.org website and the FC Plus website, which is fistulacare.org, for more information. And as we've promised, we will get the presentation and slides out to you very promptly. And there'll be some additional follow-up to address the great questions that we just didn't have time for today. So thanks, everybody. Best of luck. Hope you and your loved ones stay safe and well. And thank you again. Appreciate everyone's engagement.